In this presentation, we're going to talk about the pathophysiology and treatment of anaphylaxis. Anaphylaxis is a severe allergic reaction. All cases of anaphylaxis are allergic reactions, but not all cases of allergic reactions are anaphylaxis. So what makes anaphylaxis so bad is that it meets either one of two criteria. Either it's an allergic reaction that causes airway compromise and difficulty breathing, or it's an allergic reaction that causes anaphylactic shock through dilating blood vessels all over the body. Either one of those cases, whether it's a respiratory involvement or the involvement of anaphylactic shock, will qualify an allergic reaction as anaphylaxis. The treatment that we're going to talk about is going to be specific to anaphylaxis. Cases of allergic reaction that do not qualify as being anaphylaxis don't need to have as aggressive treatment as when there's airway involvement or the involvement of shock. So in these cases, we're looking at patients that have a histamine release. So allergic reactions come from a global histamine release over the entire body. And in the case of anaphylaxis, it's significant enough to cause these types of symptoms. So in this case, we're looking at patients that are doing severely bad and show that allergic reaction set of symptoms. Now, usually these do occur fairly quickly. If it's going to be a really bad allergic reaction, it tends to progress quite quickly. But in the case of antibiotics, oftentimes this can be delayed by a week to 16 days. So oftentimes if it's the first time that you react to, say, penicillin, then this can happen a couple of weeks after you start taking it, in which case you're actually done taking it at that point. You haven't been taking it for a few days, and you first start to show the reaction. So while it's a good rule of thumb that it occurs pretty quickly, sometimes there can be a delayed reaction. So when we're looking at treating these patients, so first things first, get the allergen away from the patient. Now in some cases this is extremely difficult to do. If it's a matter of a shellfish allergy and they've ingested it, well, it's very difficult to remove the offending agent after it's already inside the patient. But do as well as you can on that. Move the offending agent. In the case of bee stings, so the jury's still very much out as to whether or not you should remove the stinger. If you do remove it, whether you should use tweezers or scrape at it with the edge of a card. For the most part, if you do remove it, then the current suggestion is to scrape it with the edge of a card. So taking out a credit card and kind of bringing it out that way. So the thought line goes that you're going to squeeze the venom sac a little bit less and put less of the toxin in the patient. However, there are still some areas that are recommending that the stinger not be removed. So there's no solid guidance as to what should be done on that. In management of these patients, maintenance of an airway is a high priority. Make sure you keep an eye on it. That's standard maneuvers and really should be a priority on every patient that you have. In terms of giving supplemental oxygen, give an amount that's appropriate to the patient. In the case of anaphylaxis, it's quite likely that you're giving high flow in this case, since some airway compromise and breathing compromise is part of what qualifies them as having anaphylaxis. In terms of treating the patient, one of the first things that you want to get on board is going to be epinephrine. So we're talking 0.3 milligrams IM injection. This is what an EpiPen will do if you're carrying an EpiPen. And a lot of ALS providers will go straight to an EpiPen on this. If you don't have an EpiPen, then manual injection of IM epinephrine is the best option. This has many benefits. First of all, it removes histamine from histamine receptor sites, so it directly treats the cause of anaphylaxis. Also, it causes dilation of the bronchioles through beta-2 stimulation, so it treats the airway compromise, and also it causes peripheral vasoconstriction, so alpha-1 stimulation, which will then address anaphylactic shock. So epinephrine is by far the first thing that you want to go to. Now, after you've given the epinephrine, you may be giving diphenhydramine, which is also known as Benadryl, after it. Now, diphenhydramine does not remove histamine from histamine receptor sites. It cannot turn back the clock on an allergic reaction. But what it does is after epinephrine clears the histamine off the sites, Benadryl will keep it off. So it's a competitor for these sites with histamine. So if it's unoccupied, diphenhydramine can occupy that site and block it. But it's important to understand that diphenhydramine does not dislodge histamine from histamine receptor sites. Giving diphenhydramine before you give epinephrine will not do the patient any good. So make sure that you start with the epinephrine, and then if you're authorized, 25 to 50 milligrams of diphenhydramine, IV or PO, is a great option.